Welcome back. We're excited to share with you our next session with some esteemed panelists. We want to thank Jay and the PCDT for starting us off with a great summary and evaluation of the foundational information that we're really interested and focused on today. And now I'm excited to welcome our first panel. At this time, I ask our panelists to go ahead and turn on your video if you haven't done so already. In this session, we'll have three esteemed experts to discuss challenges facing patients and providers in rural communities. After each panelist offers a brief overview of their work, I'll be asking them questions. PTAC members, you'll also have an opportunity to ask our guests follow-up questions, so be capturing those as we go through the presentations. The full biographies of our panelists can be found online along with other materials for today's meeting. I'll briefly introduce each of our guests and their current organizations and give them a few minutes each to introduce themselves. First, we have Ms. Janice Walters, who is the Chief Operating Officer for Rural Health Redesign Center. Janice, welcome.
Thank you so much, and thank you for this opportunity to be part of this very important discussion today. I certainly count it a privilege to be here. And offer insights into our work supporting rural communities across the country, as well as using my talents to be able to help and support those communities. So just a little bit about myself. Obviously, you can read my bio, and I have been leading the Pennsylvania Rural Health Model work specifically since 2018. Which also included the creation of the Rural Health Redesign Center Authority, as well as the Rural Health Redesign Center Organization. The authority allows us to do work specific in Pennsylvania, overseeing the Pennsylvania Rural Health Model, and then the organization is a not-for-profit, and we oversee work being done in other states specific to rural. So given my insights in the topic at hand today, that the challenges faced by rural communities across the country, while our work really is focused on supporting hospitals, we also understand that in many rural communities, those hospitals actually employ a predominance of the physicians. And so ensuring that access to care in rural hospitals remain open is really fundamental to ensuring and preserving the healthcare access, not only for important hospital care, but primary care and specialty care. So some of the programs that we oversee, it's obviously the Pennsylvania Rural Health Model, which was highlighted in the prior session. Heard a little bit about that program as well as its outcomes. Supporting about 1.3 million Pennsylvanians with ensuring access to care through keeping their rural hospitals open. Within that work, we're doing some specific work around substance use disorder, peer recovery expansion, and using peer recovery. And we can talk a little bit more about that as we go through some of the Q&A session. We also are overseeing the Rural Emergency Hospital Technical Assistance Center. So that's the new CMS designation that allows hospitals, rural hospitals, to become just outpatient hospitals serving outpatient needs of communities. Our organization is actually overseeing the technical assistance to help hospitals across the country as they identify whether that is right for their communities or not. And then we also are doing some work in the northern border region, providing technical assistance to hospitals, really with the goal of ensuring access to care remains in these communities. If we go on to the next slide. So regarding disparities and some of the issues that we see within the communities that we serve, obviously there's common trends. So our organization, currently this number changes daily as we work with organizations really across the country, but we support about 2.6 million rural residents. And so looking at that demographic data across the country really does identify some of the challenges that we have specific to providing care in rural communities and helping those communities specific to the people that reside in them. And so certainly our data shows that, populations, at least where our organization exists and is providing services, do have a lot of health disparities. They tend to be older and sicker, which certainly we've heard that before, but certainly we have that data to show, and we can dig into this in a little bit more detail throughout the Q&A section, but certainly we have higher disability rates in the communities that we serve, food insecurity, a lot of those social lists, as well as higher deaths associated with chronic disease. as well as deaths by despair. And so some of the key takeaways that I'll wrap up my opening comments here, but some of the key takeaways that we certainly see within our work supporting rural communities is if you think about the work of hospitals as well as professionals, doctors and providers, these outcomes that we have on the slide in front of you today are with some healthcare services already in these communities. Can we imagine how much worse these outcomes would be if we no longer have primary care or specialty care in these rural communities? And again, preserving and oftentimes keeping the hospital open is how we preserve the professional providers in these communities as well. So also data, as shown, indicates that many of the same social issues exist in urban and rural communities, but rural solutions must be vastly different due to the lack of infrastructure that exists to solve the problems, such as transportation, food insecurity, etc. And then certainly I'm a big believer that there needs to be policy reform, and it's needed to align incentives across the rural healthcare continuum in order to create reasonable and pragmatic solutions to these problems. So it really does need the whole healthcare continuum, from professional services to hospital services and then post-acute, and really I would say incentivizing and paying for the type of care that we want to see delivered in these rural communities. So again, thank you. I count it a privilege to be here today and really look forward to the conversation. And I will turn it back to the moderator, Lauren. Thank you.
Thank you so much, Ms. Walters. Really looking forward to diving in with questions. Next, we have Dr. Meggan Grant-Nierman, a family physician with First Street Family Health and the Heart of the Rockies Regional Medical Center. Meggan, please go ahead.
Hi there. Thank you very much. Thank you very much for inviting me to the meeting. I don't necessarily consider myself an esteemed panelist, as somebody said earlier, but I am really humbled to be asked to share my experiences. So I'm going to bring the perspective of a rural family practice physician in private practice who has been and now will no longer be doing value-based care. So I entered the profession with a strong desire to join private practice and to provide full spectrum family medicine with surgical OB in rural Colorado. And I was blessed to find a professional home at First Street Family Health in Salida. It's a private practice that had been in business for 74 years, since 1949. And I've worked there for 11 years. When I joined in 2012, First Street had just been selected as a pilot practice for CPCI, the Comprehensive Primary Care Initiative. And so my practice of medicine has been informed by value-based care since the beginning. As many of you probably know, CPCI evolved to CPC Plus, which evolved to Primary Care First. And our practice transformed quickly and effectively. And we were very successful, really, in meeting all the quotas and metrics and milestones through these programs. However, as Primary Care First came along, we looked really hard at that pro forma. And under the very best of circumstances, we knew we would lose money by being part of Primary Care First. We considered abandoning value-based care at that point and becoming a rural health clinic. But culturally and emotionally, we were committed to the value of care that we believed in and a lot of the hard-earned, hard-fought methods we developed. And so we carried on, hoped for the best. At that point, the Aledade's exquisite marketing for MSSP ACO enablement organizations found us, and so we signed up for them in addition to Primary Care First, with the idea that if we got a little prospective money from Primary Care First, some money on the back end from Aledade, we could make enough money from the valuable work we were doing to hopefully make it through. And that, now we fast forward one short year. Our practice of 75 years is closed. Our building is sold to the hospital, and I'm now employed by the hospital at Heart of the Rockies Regional Medical Center, which is our critical access hospital and network for rural health clinics, and whose leadership team is aggressively opposed to participation in any value-based payment model. So this month has proven a very pivotal professional moment for me. So lessons that I would like to bring that I've taken away from our experience in the last decade of the value-based care participation is, one, it is good and valuable work, and patients are better for the coordinated care and the proactive management. Capitalizing on team-based care and highly functioning teams really improves the joy of practice for a physician or provider and improves outcomes. And rural practices are poised to be very successful in a lot of ways in providing value-based care because of the familial nature and the connectedness of rural communities. There are a lot of things about being rural that make doing this value-based care work natural and easy, in my opinion, in certain ways. So yes, 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 and rural communities also struggle to want to engage and to be able to succeed. We lack the available support workforce and wraparound support services that are necessary to be maximally effective, and the increased payroll expense necessary to staff the value-based work, if you can find the employees to do it, outweighs the financial return of participation in the value-based programs. The second challenge is that our data chasm is a very real thing. Rural facilities overall, in my experience, have very dysfunctional, inexpensive EMR systems, both hospital and clinic. So gathering and reporting data is very difficult. And also when you have a small population, when you're reporting data metrics, it takes one or two outliers to completely blow up your stats and change your ability to get paid. And so that's a statistical issue that we run into. And then I think downside risk contracts are not something rural healthcare infrastructures can afford to take on. It's hard enough to justify the increased overhead that it takes just to break even in a value-based model. So to be a downside risk is somewhat of a struggle. I think it's my belief that AI and technology may be a huge game changer for this in this space in the future in terms of good data collection and meaningful data, but that's yet to be proven, I think. And then the other thing that is a struggle is the inconsistent bolus funding streams that come in value-based models, chunks up front, monthly chunks, and then chunks of money at the end. Sometimes are not predictable and sufficient to help rural and small clinics or hospitals make the monthly payroll. Because as you guys know, statistically, so many rural healthcare infrastructures are operating with 30 days cash on hand. They're on the line every day. So if you have to employ a bunch of people to do the value-based work and not get paid for 18 months for who you just employed, that kind of inconsistent funding stream makes it difficult in rural communities to do that. I have some pie in the sky dreams and suggestions of what might make rural participation in value-based care a little more appetizing. And one is a model for financial support to help rural healthcare systems maybe collectively afford access to higher quality EMRs and data dashboards that are timely and accurate. And then collaborative arrangements and funding sources that I think the gal before me mentioned that help fund across the whole community organization and healthcare ecosystem in the whole county. In some places that braid funding from different departments to help rural economic development and education so that the system itself can support serving social determinants of health and growing health within the community. I mentioned earlier thinking hard about downside risk and how that precludes involvement from rural organizations. I think it's important to remember multi-payer alignment is important, not just Medicare, Medicaid, but we need our private payers to actively be part of the conversation and financially be part of the conversation of value-based care. And also just to an earlier point, resources to help support the part of the medical neighborhood that includes like EMS, long-term care, public health, social services, et cetera. That's a lot. Thank you very much.
Thank you so much, Dr. Grant-Nierman. You are an esteemed expert, and I know everyone's going to be really interested in asking you more questions. Lastly, we have Dr. Jen Brull, a family physician and Vice President of Clinical Engagement for Aledade. Welcome, Jen. Please go ahead.
Thank you. I appreciate the opportunity to speak with you all. I am currently Vice President for Clinical Engagement at Aledade, which is a company that helps independent primary care physicians form ACOs that are geographically disparate and that take on risk in a significant way. Prior to that, my life involved being a rural full-scope family medicine doc for 22 years in Plainville, Kansas, and I participated in value care with that hat on also. My heart goes out to Meggan because I know how that feels to be in a place in a space where you have limited power to make change. Aledade stats are on this slide. I won't spend much time talking about them because what I really want to share with you is on the next slide, please, Amy. So as I think about, both from my perspective as someone who did rural primary care in an accountable care organization, and from someone who is in an organization trying to solve for this, because many of our practice partners are in rural areas, I thought of 5 things that I think if this group could do and could solve for, we would make significant progress. You'll definitely hear echoes of Janice and Meggan's comments in what I have to say. The first one is to solve something that we have coined the rural glitch. So rural clinicians who participate in accountable care organizations are significantly disadvantaged from their urban counterparts because they make up a significant market share of the way that regional benchmarks are set. They are literally being compared against themselves in many cases. So regional benchmarking does not solve for them in the way that it does for urban counterparts. Solving for that glitch in the math is really important as we think about being able to differentiate the performance of rural physicians and their urban counterparts. The second thing, I'll echo Meggan. We need to invest in access, and by access, I don't mean that rural primary care physicians don't understand what their patients need. They do. Frequently, though, they lack the community and specialty resources for the patient populations they've identified, or those resources are significantly underfunded. I can't tell you how many times someone has told me about a resource to help me find community resources like Aunt Bertha, and you go online, you enter your zip code, and it will give you resources in the plenties that are 3 and 4 hours away from the patients you are serving. When you are working with social drivers of health, it is almost impossible for those same patients to achieve transportation to the resources that are being promoted for them. Third, include CHCs and rural health centers. I was excited to come in at the end of your last conversation and hear about AIP, which sounds like a move in this direction. That is wonderful. But CAW hospitals and rural health clinics have been left out traditionally of some of these innovation models because they're complex and it's difficult to imagine how they might integrate into the work that you are doing. When you instead flip it so that you find a way to integrate them in all models, I think that will be a tremendous benefit, and you may see less resistance and hesitation to being involved in accountable care. Fourth, advanced pay. Again, AIP is exciting here. Meggan mentioned resources are a big deal. When you're trying to do value-based care, you frequently need to expand your staff to be able to do that, and you need money to do that. And many times without a significant cash on hand, it's really challenging to envision how you can make that happen and keep your doors open. Being able to do advanced pay models like AIM and being able to make it easy to access for rural providers will make a huge difference. And then finally, I love what you're doing here today. And I think that continuing to connect to rural subject matter experts is going to be critical as you design systems that might support them. So many times, I think policymakers and administration officials have not well understood the challenges and barriers that rural clinicians face in their everyday life, let alone their journey to become an accountable care organization or to deliver value-based care. And so when you seek out the understanding before you write the legislation, I think it's a great place to be. So thank you very much for letting me be here today, and I look forward to answering your questions.
Thank you so much, Jen. I really want to compliment each of you. Your presentations built on each other very well and have set a wonderful foundation for us. Committee members, there's an opportunity for you to ask questions. If you'd like to pose a comment or question, please tip your name tag up. In the meantime, I'll start us off with a question. I'm really interested in your perspective on what the barriers are to effective care coordination in rural areas. And what strategies or innovations are you seeing that's actually improving care coordination? I was intrigued by some of the things you were saying about looking at blending and braiding funding and looking at this as a county-wide approach. So would love to hear your thoughts about that. And Janice, why don't you start us off?
Yes, thank you for the question. So certainly some of the barriers, as my esteemed colleagues and subject matter experts have already stated, it really is the lack of infrastructure and resources. So I had to smile when Jen made reference to Aunt Bertha, and the idea that there's a plethora of resources out there, and in rural communities there really aren't. So lack of we call it community benefit organizations or some of these other infrastructures that really need to be present in order to meet the needs of the communities. And so often, even within our program, certainly our payment model within the Pennsylvania Rural Health Model really is asking our hospital leaders to change how they typically viewed and really come to start serving as the convener in that community to bring the healthcare continuum together. And so given their position within most of these communities as either, one of the largest either employers or healthcare organizations, to say, we're not asking you to solve the problem by yourself, but help serve as the convener to pull organizations together. What we see is the infrastructure's not there. And so, the barriers of funding, it all comes back to funding. I'm a healthcare is actually my third industry. I started in manufacturing, I was in communication, and now I'm in healthcare. And I really believe, just going back to basic business principles, we get what we pay for. And so those investments, just the funding has not been there. And so I truly do believe, too, in rural, one of the challenges that we face within CMMI directly is we know that by statute, they have to produce savings or improved quality for the same cost. But yet there's not enough, I would say, funding in healthcare alone. So you do have to figure out how to bring in these other revenue streams from a community perspective. So, there's a lot of disparate, whether it's USDA grant funding or, mental health, at least in the state of Pennsylvania, mental health payment is a separate payment stream. Then you've got healthcare, we've got dental, we've got vision, then you've got funding for other community benefit organizations. But how do we build a system that everybody aligns for the improved health of the community, and bring those funding sources together? So I don't know that I have anything new to share beyond the barriers, because I think we all recognize the barriers that exist. A lot of it does come down to funding, but in terms of innovative solutions, I can tell you within the work that we're doing, we are seeing hospitals invest in care management strategies that typically have been done thinking of primary care, but how do we bring, that care management for the people that are using the emergency rooms as their primary care? There needs to be able to somebody step in and allow for that care coordination. So, innovative strategies that I've seen, a lot of our hospitals are investing in care coordination strategies versus discharge planning. Discharge planning has really been the work of the hospitals up until this point. Now they're truly investing in care management, care coordination. Using peer recovery specialists within our emergency room. So again, trying to intercept where the need is and identify, okay, how do we invest in different type of infrastructure that certainly our payment model, we believe, allows for that, because it's no longer looking on volume, but it really is looking at value. And then, social determinant of health screenings. I'm a big proponent of data, and I completely echo the sentiments of my colleagues. Data is greatly lacking within the rural infrastructure. But really, you can't fix a problem if you don't know the problem exists. So simple things like doing social determinant of health screenings for certain populations that come into the emergency room or into the hospital. Taking very pragmatic approaches to say, what can we do within the confines? What resources do we have available? And I would say starting with use data to identify pragmatic solutions that can be done without maybe a lot of additional funding. However, additional funding is needed if we truly want to move the dial. So that's how I would answer that question.
Thank you so much, Janice. Meggan, we'd love to hear from you.
So yeah, I guess when I was thinking through this question, my mind went to the concept of a little bit with care management, but also with transitions of care. Is that some of what we can talk about at this juncture?
Definitely.
So the idea of TCMs or transitions of care management from a primary care perspective, that's something that our clinic worked to do pretty well. And I think with support from some of the data structures from data dashboards from Aledade that we use, we were able to improve on that. But in rural, I think sometimes transitions of care can be easy in some ways. For example, if I admit my patient from the clinic to myself in the hospital, I see them in the hospital and I discharge them back to myself in the one hospital in town. That's kind of easy. But a lot of our patients get sent out. They get flown out to Denver, they get flown out to Colorado Springs. And so those are the transitions that are a little bit more tricky. Back to data, the ADT feeds that can go into our COREO or HIEs, Health Information Exchanges, that can be helpful, but truthfully, a lot of small clinics, small practices, small hospitals can't afford to access or choose not to afford to access the rural health, the HIEs appropriately. And so there is a struggle that we found of really, unless they were across the street from us and we admitted them to ourselves, is really figuring out timely ADT feeds and triggers to let us know when our patients are being admitted or discharged from various places. Long-term care facilities don't often feed in ADT data in the same way. So as a small clinic, it's hard to hire yet another full-time equivalent to chase down who's being admitted where, when, and how do we capture them to transition them back. For the most part, when we do succeed at doing that, the other struggle comes into, as was alluded to earlier, just the lack of the wraparound services necessary in the rural community to receive them safely so that they can stay home. Timely home health, sometimes pharmacy ability to get your meds once you get home. In the community where I grew up, the pharmacies are an hour apart from each other. So most people have a 30, 40-minute drive to a town with the pharmacy. So getting meds when you get home in a rural community, sometimes that falls through the cracks. So the support services to catch them when they land at home and help them safely stay at home can be a big part of the struggle. I think that our community rural critical access hospital, they have discharge planners who do one token phone call 48 hours of discharge to be sure that the patient still has a pulse, and they say follow up with a PCP and call it good. I think that's about as much as we have from the hospital side for care management in that way. From the clinic side, we had nurse care managers who would bulldog these patients, hunt them, find them, call them, chase them down to try to manage their care, which worked well for us, but also, as was mentioned earlier, that's an expensive overhead that was unsustainable to be able to provide that good care. So I don't know if that answers the question well.
Thank you so much, Meggan. And Jen, we'd love to hear from you on this question.
Yeah, I think I have the benefit of sort of seeing across about 1,500 practices that we partner with at Aledade. And I think we've seen three ways that people are successful in care coordination, including transitions of care. The first way is, as Meggan referenced, an embedded person in the clinic whose role is care coordination, whether that's a nurse or a social worker, but someone whose job description includes the list of tasks of making sure that patients receive the services and connections that they need when they're available within the community. That faces the challenges of the practice needs to pay that person, and there needs to be a sustainable source of revenue to support that person's work. The second way I think that we have seen success is when practices partner with their communities and are taking advantage of community-based grants and resources that are designed to communicate and coordinate resources. So, for example, if you have a city planning grant or a HealthWise county grant that are working, you can oftentimes partner to make those resources more transparently available and accessible to your patient population. That relies on the presence of grant funds and visionary people within your community that are doing this kind of work so that you're not trying to do it yourself. The third way I think that we've seen success is through the use of telehealth and teleservices. So not all services that patients need at the time of discharge or in any other care coordinating setting are available in a telehealth platform. But when they are, and the primary resources here are in the mental health arena, so counseling services or access to mental health providers. This tends to work pretty well because people don't have to leave their homes. And fortunately, there are fewer barriers now about people having devices that are accessible to be able to do telehealth type supports. And now funding supports that for the people providing that care, which means that there is a revenue stream for doing so. So I'm not going to downplay at all the barriers that Janice and Meggan presented. I think they are very real. And I can tell you that as a practicing clinician, I absolutely saw those every day. And I think there are some bright spots and some ways that if we amplified those bright spots, so funding in advance for people in the clinic, grant streams for people in the community, and continued payment for telehealth, I think that those are places we can amplify where there's some good things happening and spread that.
Thank you so much, Jen. Jim, I'll turn it to you.
Yes, thank you. I think Jen and then probably Janice, I was going to try to see if you both would comment on this. When we looked at the data, we see some bright spots in the rural communities, and we understand that rural healthcare isn't 100% broken. That is, in some places in rural America, it's working, and especially in value-based care. But on average, we see the results to be suboptimal, and that by and large, when you compare rural versus non-rural areas, we see that the rural areas aren't making the kind of progress that we hoped for with regards to value-based arrangements. And I was curious about, I got a couple questions that kind of crossed my mind. And I think, Jen, you just kind of touched on it a little bit, but maybe there could be a little bit more exploration here, which is, what do you think are the differentiating factors that create bright spots within rural America when the story sounds so dire? And on the Aledade question, or even Janice, in your organization, do you do assessments before you go into a community? And what are you looking for that would help you predict success between one rural community and another as you choose to work with these organizations in order to kind of create forward progress?
Sounded like you were pitching that to me first, so I'll take a stab at it. And what I understood you to say is, when we see bright spots, why are they bright spots? And what sort of evaluation do we do or could we do to find those bright spots as we're looking for successful places? So I think the answer to the bright spots question is that all the barriers that Janice and Meggan and I have presented are lower in those places as a starting place. So we all see places where there are enough primary care physicians to serve the community. That means there's a little bit of capacity to take on this new work of value-based care. We see places where there are great collaborations between the hospital and the community physicians, between the community and the hospital, that really mean that there's a chemistry there and a supportive environment that make it a fertile place for this to grow. And some of that is not very predictable in the data, but you might see the data and be able to find that in the community that's there. I think that's hard when you think about, so how do we predict that? I can share with you, Aledade absolutely looks for places where and I wouldn't say where we think people will be more successful, but where we will need fewer or more resources to support the work of value-based care. We don't exclude practices because they're not high performers. We just see them as opportunities for a larger delta. And so, yes, there is data you can look at. There's lots of data from CMS that is available to help you spot where things are happening well, where practices are delivering what looks like great value-based care. You know, how many AWVs have they done? How many transitions of care have they done? What does their readmission rate look like? All the things that I think we all know to look at will point at a community that is doing better, whether intentionally or through good luck. And most of the time, it's very intentional. Having said that, we love partnering with any independent primary care practice. And when we see places where people are maybe not as far along on their value-based care journey, maybe they haven't had the opportunity to be involved or be in CPCI or any of these other initiatives, although that's getting to be a smaller group of people, we just see that as an opportunity where people may need to enter the world of ACOs in a risk-bearing status, and they may need a year to get those muscles built and be ready to move to risk. Being in risk is certainly a better proposition from our perspective because it incentivizes and rewards the work of value-based care much more strongly than not being in risk. But some folks just aren't quite ready for that right as they start.
Would any of our other panelists like to comment?
Sure. So I'm happy to jump in here and add a couple thoughts as well. So I've had a little bit more time to process the question than Jen did, but I think I can attribute the success of what we've seen to a couple of things. So the first is leadership. And does, the local leadership in these communities recognize the need for change? And so I will say, at least in the Pennsylvania Rural Health Model Program, it was all voluntary. The leaders that came to the table, certainly I would say were visionary and they recognized the need for change. So certainly, as we, talk to a lot of hospitals, talk to over, 30 plus 40 hospitals, 18 of which came to the table, I would say it was more innovative leadership, recognized that there needed to be a change and wanted to be part of that change, wanted to be part of the test. There were a few that came out of desperation, that they knew this program was probably the only way that their hospital might stay open, but even still recognized, the current, paradigm fee-for-service was not going to yield them a longevity for their organization, but really leadership. And I would say the forward-thinking nature of leadership, wanting to be part of the new mousetrap or the solution. The other thing, it's a very pragmatic. Does the math work? So we want folks to go into value-based, but if that value-based arrangement doesn't produce a better result than what the current paradigm is, why would they change? So Meggan, gave that example where she really wanted to be part of this. The math didn't work. And so in terms of assessments, whether it was in the Pennsylvania program or what we do within the rural emergency hospital space, we start with, does the math work? We certainly educate, what is the new potential opportunity? But then the next step is, does it produce a better result than what you're currently having right now? Is there the opportunity for improvement? Is there enough incentive in that value-based work that actually leads to a more sustainable path? To go back to a comment that I think it was Jen made about the critical access hospital. I think that's one of the issues that we currently see, that critical access hospital, cost-based reimbursement, that piece of the pie for many states is getting smaller and smaller because we see, Medicare Advantage, that there's an increase in Medicare Advantage, which is actually decreasing, the opportunity under cost-based reimbursement for the critical access hospital. And the other thing that I like to say about critical, it was great, but it still keeps folks at cost. Even for that piece of the pie, the best they're going to do is actually cost, or now slightly less than cost, with sequestration. So how does, even in value-based, the hospitals that chose to participate in our program for that Medicare book of business, it's still cost-based reimbursement. How do you ever get to where it's you can, have a profit margin if you always come back to cost? So the incentives have to produce a better result in order for a leader to actually embrace the math has to work. So very pragmatic approach. Does the new paradigm offer something better than the current? So again, leadership, we do a financial assessment to say the math works. And then I think there has to be a commitment to transformation. So at least within the Pennsylvania program, then in exchange for that global budget, that predictable payment, we ask them to make a commitment. What are you actually going to put to writing that you will commit to transform? So it's one thing to say we're moving to value-based. It's another thing to actually be held accountable for that commitment. And so thinking about the hospitals and even in the rural emergency hospital space, who's coming to the table. Obviously, the math has to work in order for them to even consider the new designation. In the Pennsylvania program, it was, does the math work? Do we have leadership that's committed to making the transformation? And I do believe that's what's yielded the results that were shared in the prior session, where most of our, it is favorable. The Medicare member per month spend is still less than the national average. And we have seen avoidable utilization decrease, the right care being provided in the right setting. And our quality indicators are being maintained. So that's how I would answer that question. Thank you.
Thank you so much. Lee, I'll turn it to you next.
Thank you, Lauren. Well, Meggan, my heart certainly goes out to you. I'm so sorry you're having to go through this, but thanks for your commitment and getting up each morning and serving your community best you and your partners can. I'm fascinated by your all's experience, you and Jen particularly, of going from walking the walk on a value-based payment journey with your patients from a practice perspective, now larger to a system perspective, and trying to implement that from small to large. And so from a perspective of this wrinkle you brought out about it's hard to get facilities, who are often the employers of, if not the physicians directly, the assets you need to connect the dots in a community, all those employees. This wrinkle you brought out that it's hard to get leaders of cost plus reimbursed facilities to see that there's any squeeze for them, if you will. There's no juice. So I from an alternate payment mechanism perspective, I would love to hear your all's advice. What would you recommend that we can pass on to the secretary that has worked in changing the trajectory? If you had the federal policy magic wand, how would you pay in rural communities differently to change the trajectory of these health systems?
I'm willing to go first. So I truly do believe that we get what we pay for. And I think the Pennsylvania program is testament to that we are paying our hospitals a global budget. The intent was predictable. As was brought out in the prior session, that has proved to be challenging, but that all comes back to, the current methodology. And I do believe there's opportunity to refine methodology. But if we truly want to engage facilities on this journey, we have to align the incentive that actually allows them to do that, especially in rural communities. So having been a former rural critical access hospital, finance leader for the organization, as much as I wanted to not have people presenting in the emergency room because they didn't need to be there. The reality is that rural provider needs every billable service in order to stay open. They can't afford to naturally do what's in the best interest of the community when you need billable services just to keep your door open. So if we truly want to engage rural hospitals on this journey, we need to align the incentive that actually allows them to do that. So one of my participant CEOs, when he came to the program and signed on, he said, I feel this program for the first time actually brought me to the table as a partner in this journey versus being treated as a cost center with everybody trying to keep the patients out of the hospital. I'm now at the table as part of the partnership, and I no longer, if I actually keep people out of my hospital because they don't need the care and they're getting good quality of care and they're generally healthier, I don't have to worry about payment for that. I'm suddenly incentivized to help reduce avoidable utilization. And so it's allowed them, and then you give them the data that they need to identify who's coming into their hospitals that don't need to be there. Suddenly there's the incentive for them to hire the care manager to keep the patient out of the hospital because they no longer have to fear their revenue stream is going to be hurt because of it. Now, there are controls in our program that we don't just want them going someplace else. So we do have to monitor that a little bit, that the patients are truly getting the care they need, not being, turned away, and they're not going someplace else, but they actually are, being healthier. So to me, it's aligning the incentive of how do we actually, want these rural hospitals to operate, recognizing we have to keep the asset in the community. Because on the flip side of that, if we don't do something, we're not going to have rural hospitals left. And again, that's going to have a domino effect because oftentimes they're employing the primary care, the specialty care. So we want to make sure access to care remains in the community, and I fully believe you do that by fundamentally changing how rural hospitals are paid. I'm obviously a proponent of global budgets because even ACO frameworks are built on volume. Most ACO frameworks, there's a volume incentive. So if I had the magic wand for something to come out of CMS, it would be allow global budgeting more broadly to rural hospitals across the country, because it really does allow them to do what's in the best interest of their community without having to worry about, keeping their doors open because there's predictability of payment. And then for critical access hospitals, there has to be some way to actually get paid for value, because the critical access hospital as it stands today still comes back to cost. So even if they do reduce avoidable utilization for that Medicare fee-for-service book of business, they run their cost report, they get paid cost. It's got to be a cost plus a value type of incentive.
I'll add, so having worked in a rural community with a critical access hospital, and when we joined an accountable care organization in 2015 for a 2016 start year, the board, who are wonderful people and are collaborative, were scared to death that we were going to close their hospital because of joining an accountable care organization and reducing the need for patients to be in their hospital. And that felt very scary for them, which, even though we are in a small community and all friends, it made them feel very defensive. The way that we got to an immediately better place was to align not on payment, but on values, which is you are here and we are here because we want our community to be healthier. The work of accountable care and value-based care is designed to make our community healthier. And as soon as we got to an aligned incentive, then we could have conversations about how to make sure that it did not result in a financial downfall for the hospital. And the way that we frame this in our community is there is no doubt through numerous studies that what patients need more of is great primary and preventive care. Hospitals can be part of primary and preventive care. And instead of focusing on revenue from heads and beds, if instead we focus on revenue that is on primary and preventive care, helping our community be healthier with things like fall prevention programs and preventive imaging and preventive services and urgent walk-in care instead of ER care, if we can flip the book of business for the hospital to that side, and we love for them to be in that side, it's not a competition, it's a collaboration, then they could see how they can both deal with their cost-based reimbursement and be part of the solution for a healthier community. I'm going to plus one, though, to Janice's comments that we need to think more about how rural hospitals, particularly critical access hospitals, can be part of cost plus value. because that's still a sticking point.
Meggan, did you want to add comment as well?
I guess just simply to agree with the idea of having cohesive incentives across the medical ecosystem. And in our experience, just day to day, we would work very hard to keep a patient from having to go through the emergency room and get them over to the hospital for maybe an infusion in the infusion center to avoid an ER visit. And the nurses at the hospital would say, you should just go to the ER, and undo everything we just did. And it's because of those misaligned incentives. And so kind of a global incentives across the medical neighborhood is certainly important. And then payment structures that look at braiding funding from other federal organizations outside of HHS and insurance so that we can invest in the whole community. I'm not for sure of the details. I'm not fully educated on this, but I believe some of the ACO programs have a requirement where a certain percentage of shared savings is required to be reinvested into the community for the health of the community. Is that correct to people's understanding? And so if there was a requirement from the money that is saved to the payers, that a certain amount of that can then be reinvested into community structures and supports such as EMS, long-term care, public health services, so that the community can better strive to succeed in the health of the community. I think that can be pretty helpful.
Thank you so much, Meggan. Angela, I'll turn it to you.
Yes, again, thank you all for participating in this today. Obviously, rural healthcare is a big issue nationally, and it's a big issue for PTAC and CMMI. And hopefully we can come out of this in the next few days and over the next few months with some specific recommendations and programs to address rural healthcare. I think one of the very basic questions that we've been wrestling with is, what is the definition of a rural community and rural health? And as you know, as we've looked at the data, it doesn't come across as clear that there's one single definition, that there's a spectrum of rural environments, from those that have a little bit more resources to those that have very little, and are across a different kind of geography. So I'm curious to hear from each one of you how you think about rural as a definition of a rural environment, and how you would help us define that, and if you agree that there's a spectrum of rural environments, and how you would help define those. So maybe if we could start out with Meggan on that.
Yeah, I have recently learned to better understand that there is a huge variation in how people interpret rural. My interpretation of rural is somewhat similar to maybe what Dr. Brull experienced in Plainview, is what others might consider actually frontier, as opposed to rural hospitals that are 40 minutes away from another rural hospital. So absolutely, there's a huge discrepancy of physicians and patients who live 2 hours from the closest cardiologist and the 3 or 4 hours to the closest labor and delivery, which would probably be considered more frontier. But that's the reality of where I grew up, and never thought otherwise. That's definitely legitimately rural and frontier. And then we have small critical access hospitals in parts of the country in the southeast, for example, that are wailing and gnashing teeth because 40 miles away a hospital closed, and God forbid we drive 45 miles to the next healthcare. To me, that's a luxury. That's lovely to drive only 45 miles. And so absolutely, frontier and rural are two different things. I think that would be an interesting opportunity when we look at risk stratifying health populations for value-based, population-based dollars, is maybe a zip code and distance from healthcare services related risk score that automatically helps stratify those differences, because rural that is 50 minutes away from Boston is not the same rural as Plainview, Kansas. It's just not. And so the resources, the finances, and the logistics are just not the same.
Thank you. Jen?
Yeah, when you asked the question, the phrase that came to mind is like, you know one when you see one, and that doesn't help you at all. I think Meggan's comments resonate with me in terms of there is a spectrum. And I think it's important to recognize the spectrum because people who are an hour from Boston are still an hour from Boston. They're not in Boston. And their challenges are different than those who live in Boston suburbs and those who live in Salida, Colorado, or Plainville, Kansas. And so I think recognizing the spectrum is something I would advise. I will double down on Meggan's comments that I think there are some key drivers that you could evaluate. And some of that is distance in miles, and some of that is distance in time, because 45 minutes in Kansas is, 45 miles in Kansas is 45 minutes. 45 miles in Colorado might be a couple of hours if you've got some mountain passes to go through. And so one of the things I would do is recommend that you identify things like where is the closest emergency services, where is the closest key specialty services, not necessarily every specialty, but some of the most important ones to primary care sensitive conditions. Where is the closest obstetric services? We have a lot of obstetric deserts in the United States. And then how far are those in miles and time to patients? And I think that more than population is going to tell you who needs to be considered and classified various strata of rural healthcare services.
Great, thank you. And Janice?
Yeah, I don't know that I have a lot new to offer other than to echo Jen's sentiment. It has to be about time as well, because when you're dealing with mountainous terrain, mileage does not show that as it relates to, going over mountains in the state of Pennsylvania, and to the point of mileage, a map only tells a portion of the story. So certainly that has proven to be a challenge in our current program. We use a state-based definition of rural. And so within the Pennsylvania, within the state of Pennsylvania, we had a definition of any county that had less than 284 people per square mile was deemed rural. And I know when you're talking frontier, that's a huge amount of population. We've certainly heard that. But that did create some issues in terms of, qualifying for the program. We had hospitals in the state that were deemed rural from a state perspective, but not from a federal perspective. And so certainly definition is something that would need to be solidified. And I would also encourage to get other stakeholders at the table to ask this question, especially if you're looking for all payer types of programs, because it's one thing to come up with a definition for a Medicare program, but if we're asking, all payers to come to the table, they certainly are more apt to want to pay a global budget to one type of rural hospital versus another type of rural hospital that in their mind might be more urban, but because of the county, the demographic of the county, the hospital is deemed eligible. So I do think there would be broader stakeholders that we should get their voice into that question, especially if we are asking for all payer types of programs.
Great, thank you all, appreciate it.
Jenny, I'll turn it to you.
Good morning, everyone, and thank you, Meggan, particularly for your passion and all of the sort of commitment that you've displayed. I know, having been in multiple VBC transformation roles, this is really hard, and you've spent a lifetime doing the right thing for your patients, and so thank you to all of you panelists. The question I have, and would love to hear from Jen and all of the panelists, is when you think about measurement and data pooling for risk, I know one of the struggles is really on how rural populations, particularly RUC9 populations, have such few eligible participants that it really, one or two outliers can throw the data off. So I would love to hear your thoughts and recommendations around how you would envision data pooling around medical service areas and counties.
Thank you. I'll bet there are other folks who can speak to this more eloquently than me, but I'll tell you two thoughts that come to mind. The first is in MSSP and in other innovation spaces, in general, rural folks are aggregated, and I think that's very wise because, yes, if Jen Brull with her 200 Medicare patients has an outlier in cost, it's going to sink the whole boat. But if Jen Brull is a member of an ACO that has 10,000 Medicare patients, the one that I have that is an outlier won't sink the ACO's boat. So globally, I think thinking about larger denominators is a good thing for rural folks. And anything you can do to make it easier to aggregate lives across geographically disparate populations is wonderful, which I think we're in that space. When I think about specific metrics and measures and things like blood pressure control and A1C control and some quality metrics that we're working on, certainly you'd like to be able to provide people with feedback of their performance, and the more direct feedback and transparent feedback you can give, the easier it is to improve performance, both in a quality and a cost-based environment. So I think that there's a balance in that space between providing performance data and using that data in an individual sense to determine performance. And there's a difference between someone who has 200 patients and 100%, 100 of them are out of line for performance versus one of them is out of line for performance. And I think you can treat that data differently. I think the other thing that helps is something that Meggan said earlier, which is if you can align across all payers, then you grow your patient population and your denominator from a couple of hundred Medicare patients to a couple of thousand all-payer patients. And that makes a huge difference when you're looking at outliers because you've just grown your denominator, but it's the same person providing care to all of those people.
I would like to agree with Jen for sure. I hope this doesn't come off as like the Aledade celebration presentation, but we worked with Aledade just for 1 year, and their dashboard is awesome for providing meaningful feedback and to aggregate a bunch of data. So working with that organization was really helpful for us as a small practice, and then having that enablement organization start with the contracts of more multi-payer alignment so that we're doing the hard, putting all the work in for the Medicare dollars, and all the private payers are just benefiting and just getting richer from our hard work. But actually having them recognize and value the value-based work too was super helpful. So I definitely want to agree with that. When you were talking about data pooling, as in aggregate pooling, OOL, or pulling, as in pulling data, I heard that two different ways at the initial question.
I was thinking about aggregate pooling.
Got it. Okay. Then I'll let the next person talk at that point then.
Yeah, the only thing I would add to what has already been stated is really the identification of rural relevant measures. So I do know that's one of the things that within our Pennsylvania program, some of the metrics that were originally identified to measure outcomes, we realized that they weren't necessarily rural relevant. And so we spent a lot of time working in partnership with CMMI to come up with metrics that we did feel were rural relevant and maybe less likely to be impacted by small numbers. So the identification of the measure, I think, is as important as then, being able to aggregate it and pull it. So also coming up with metrics, a quality program. And I think one of my colleagues has already said that, I think value-based is an opportunity to what are the metrics that we want everybody within a program using, and standardization of that, because it also helps not only from a program administration perspective, but also, the clinicians that are on the front end. So many times being a former healthcare finance leader, I felt I was chasing the dollar. I was trying to chase the carrot. And in these small facilities where we know resources are already strapped, we didn't have the time to chase the carrot. And so if you standardize that where everybody is pulling in the same direction, it's already been said before, alignment, getting everybody to agree on what the outcome is that we're looking for and how we're going to be measured against that and get that alignment at the beginning. It makes the whole value-based journey a lot less arduous for everyone involved if we all agree on what the most important outcomes are that we're trying to measure at the beginning.
Thank you.
Okay. Larry?
Well, first of all, I want to commend Jay and the PCDT for compiling such a fantastic set of SMEs for this session. There certainly is tremendous experience in the three of you. All three of you present a very significant statement around the problem with access. And that access not only has to do with distance and time, it also has to do with, do you have available personnel to provide the services? And we can't possibly put together value-based structures if half of your patients are leaking out to out-of-network specialty sites that are 50 miles plus away. So my question, and I don't think I heard you address this, how do we fully leverage the primary care base that we have there? Jay eloquently presented the fact that the disparity between the PCPs in rural versus the PCPs in non-rural, although it is less, is significantly less disparate than that for the specialists. I'm a gastroenterologist, so I keyed in on his GI number, and there's 6 times as many gastroenterologists in the non-rural area as there are in the rural area, which begs the question of training and broadening the expertise of the primary care. My colleagues in GI will probably not want me to say this, but we need to be training PCPs to do colonoscopies more. And we need to train dentists to do more than just crowns. They need to do some endo and some oral surgery. So we can't build value-based care unless we have the pieces there to perform the care. So what are the three of you seeing done to expand the PCP abilities and raise them to a higher level of their performance than we see in a more urban environment?
So I'm happy to go first on this one. I can tell you we fully and firmly believe that in order to address the needs in the rural communities where we're present is we need to develop additional types of primary care extenders. So we certainly know that, transportation is a huge issue in rural communities. So how do we develop other types of resources in the communities that can, I'm going to say, stretch the primary care that's already there through concepts such as mobile integrated health? So are there ways that through protocols and we can develop other folks to support that care team and using, for example, some mobile integrated health strategies, working with technical schools in these rural communities? Can we develop additional, I'm going to say, hands and feet of the primary care provider that would be working in partnership with them to expand that knowledge in the rural community? So one of the things we're exploring is the use of mobile integrated health solutions, broader paramedicine type programs. How do we build out a better clinical team? Because none of, the primary care shortage, the ability to recruit a primary care doctor to rural America, that challenge is not going to go away in the near term. But we also know, one of the things I believe, again, having lived rural my whole life and have watched the demise of my community, is, how do we bring some economic alternative career paths, et cetera, to start addressing the economic issues in a lot of these communities? And is there a way to develop alternative types of providers, of, whether it's the community health worker, paramedics, EMTs, how do you develop other types of care and allow them to practice at the full extent of their license to bring additional primary care to the community, and make sure from a payment policy perspective, the payment is there to allow for these other types of providers to be paid, and address the need that way. So that's how I would say we're viewing this within the Pennsylvania program is, and some other, within the REH space, is there the opportunity to develop other types of care providers to extend and partner with the primary care that already exists in that community to meet the needs.
I can comment just a little as well. So I did my residency training at Via Christi, which is one of the handful of programs in the country that do train their residents to do full spectrum family medicine procedures with the intention that they go to rural Kansas, rural Colorado, Africa, and do mission work. And so there are a few training programs that train family practice docs to have that higher scope of practice. And in my experience of watching the classes of residents that go through, everybody grabs the bull by the horns. We're going to learn all the things and do all the things for everybody everywhere. Nobody lasts that long doing that, because saying we should have the family docs do the scopes, which back in the day they did. Many people have, and eventually that's been burnt out because you can't do everything well in an environment where in a court of law you are not going to be able to defend yourself against a GI doc. Do you know what I mean? Like the medical legal neighborhood of that, having them do all the things is really great. And it's also very risky, and it's not very sustainable with quality of life. So I definitely agree that allowing physicians who can be trained to do a higher scope of practice is a great goal. There are residency programs that do that, but those residency programs have a hard time fighting to maintain that training from the specialists at that level to be willing to train FPs to do it. So it's a struggle. And then when they get out there, they realize that it's not compatible with life to do the scopes, the deliveries, the C-sections, the ER, the hospitalization, all the clinic, all the social determinants, health, solve the housing crisis. Don't forget to check on them at home because EMS can't pick them up. You may need to go and pick up their prescriptions because we don't have pharmacy. So in the same breath that we say, we need to support primary care, all of the solutions all come down to, we should ask primary care, teach primary care to do that. Let's add that to what they're doing. So we're kind of squishing from both directions, and in the middle saying, oh, by the way, we're going to financially squeeze you and put you at risk too, by the way. So I'm hearing a lot of interesting forces and potential solutions that as a primary care doc feel like a squeeze, a pull, and a push in every direction. So I agree that extending and getting support networks within the community, if that was possible, to take off some of the burden of doing things that physicians don't necessarily need to be doing. Being very mindful of not adding more administrative burden to participate in value-based care, computer clicking boxes for the sake of clicking boxes, treating a payer in a computer and a dashboard instead of a patient. That's things that we're adding to physicians as well in rural communities. And then we're wondering why they aren't sticking around. We have to be really mindful to pay attention to all the things we're going to add and ask of the already shrinking workforce, because what we're seeing is primary care docs are saying, I'm done with medicine, or I'm done with the payers. I'm going to direct primary care. I'm removing all of this. I'm getting back to my patient. Thank you. Goodbye. So I agree that family medicine docs can deliver babies and do C-sections. I do that currently. They can do scopes, but to say that all the things can be done by the PCP when there aren't enough of them is a hard, that will take decades of culture change, medical legal malpractice change, financial change, reimbursement change before that's, I think, going to be a reality again. I'm hopeful. I don't mean to sound negative, Nancy, because I really am hopeful, and I love doing full spectrum care. And I don't ever want to stop delivering babies and working in the hospital. I'm not going to stop doing that. But across the community, residents aren't trained to do that. Residency programs are disincentivized disincentivized to train residents to do that. And the medical community is actually not welcoming to that kind of full spectrum provision of care from family medicine in most parts of the country.
I'm going to amplify just a little bit of what Meggan said, which is I absolutely think family physicians are capable of providing expanded services, with the caveat if there are enough of us, which means that you get more lifting up than pressing down. And there is a shortage of primary care specialists in rural communities, just like there is a shortage of gastroenterology specialists in rural communities. And so I don't think the solution is shifting the work of various preventive services, colonoscopies being the example we're talking about, but there are just hundreds of them, to the primary care specialist. I think it's more about ensuring that there are a sufficient quantity of primary care specialists to serve the population of the United States, urban and rural. We just feel the gap harder in the rural areas because there aren't as many of the other specialties to take care of the other parts of the patients in those areas. And to me, that comes down to reimbursement, which I think you all are working to solve. I think value-based care is the space for primary care to benefit from. We are the folks who are looking at people's total and comprehensive cost of care. We are involved with every organ system, with every transition, with every part of people's lives when they are needing a healthcare system. And so I think the more that we are able to make a path forward to do advanced payments, do predictable payments in value-based care, we will make primary care specialties more desirable as a specialty to pursue for students who are graduating from med school. Will increase the population of primary care specialists throughout the United States, which will in turn increase the population of primary care specialists in rural areas. In addition, there's some really nice incentive programs in many places. Kansas is one of those states where you can go to med school for free if you're willing to give 4 years of your time back to a rural area. And if we had enough of that going on, even if we have a different population of physicians coming and going in rural areas, the problem is once somebody leaves, there's not usually somebody in line to take their place like there is in an urban area. And so we need to increase those programs that pay primary care well and that make it attractive for them to spend some time in a rural area, just like they might spend some time in Denver or Kansas City. Thanks.
Thank you all so much. We have about 5 more minutes left. Jay, I'll turn it next to you.
Janice, you touched on my question briefly. You know, we're not talking about dentistry and dental care today, but mobile dental care has been used to fill the gaps because there's a tremendous, there's no access for dental care in rural America. Let's just call it what it is. And they've used mobile services to fill the gap. So I'm curious for each of you, what's your experience been with mobile services to fill some of the gaps we're talking about in healthcare delivery for rural America?
Yes, so I'm happy to take lead on that. So not in this current role, but when I was the financial leader for a critical access hospital in the state of Pennsylvania, we actually did introduce mobile clinics within our rural health clinics. And so that's how we began addressing the need of lack of dentistry within our service area, was to do mobile clinics and bringing them into the rural health clinics. Generally, as I administrate, the programs that the Rural Health Redesign Center, has been privileged enough, to manage, we really do believe there's a huge opportunity to do mobile integrated health solutions. Anything from social determinative health screenings, taking as physician extenders can go into the home and begin doing some of this, even things like prenatal. We have a colleague that we work with who has experience doing even prenatal work and doing some of that through mobile integrated health. Certainly we're not going to be delivering babies, but what are are the opportunities that if we develop the right workforce, because that also then addresses some of the transportation barriers. So, we do have examples of where this type of program is working, and certainly looking to replicate that, but understanding that policy changes will probably be needed. Again, reimbursement at the federal level to make sure that their reimbursement. So, for example, one of CMMI's programs was the ET3, which, it was a alternative reimbursement model that would allow, EMS systems to get paid, through responding. Unfortunately, in a lot of these rural communities, traditional Medicare is getting smaller and smaller, but we really need policies that do allow for, EMS to be reimbursed, not only when they transport somebody to the hospital, but when they go out and do this type of in-home, making sure the reimbursement is there. The use of community health workers, at least in the state of Pennsylvania, all of that has been grant funded to date. And so allowing the policy both at the state and federal level to make sure that there's payment for these services is also going to be a big piece. And then also the workforce development. So we think it's a very viable strategy, but it's again getting education, your technical schools as well as your workforce, labor and industry to the table, as well as policy then to make sure that there's payment for these types of services when they are delivered in the rural community.
Jen and Meggan, did you want to comment briefly?
I'm solidly nodding my head to Janice's comments.
I don't have much experience with mobile delivery systems to have much to say.
Jim, I think we can fit in your question then, if you make it brief. So we have about 3 more minutes.
Yeah, my question is really such a big question. It's about can the market solve this problem? Which is, it sounded to me like that the all-payer model, particularly as an example, might be a destination that we might want to look toward as a solution to help make progress. Can the marketplace be motivated to do this in your experience?
I'll give you my one-liner. Not until the marketplace has the same incentives that we do. Not until saving money makes you more money than putting a head in a bed or getting $1 for making a widget. Like we have to change the alignment of the marketplace before they're going to help us solve this problem.
And I would echo that. That would be, we get what we pay for, and until we fundamentally change the incentives. So I do think we need to compete on something beyond volume. And so I do think the marketplace can, if we change what we're competing for, which is high quality, improved care, value-based. So my answer would be yes, if we get the right incentives and compete on something different.
I would agree, I guess, with what the other 2 gals have said, but I'm also just want to spit out the curious nature of what the market is showing us right now, which is the overwhelming investment from private equity, venture capitalists, the vertical and horizontal integration that is going absolutely haywire and bonkers because there is billions of dollars being made by people who are not providing health care, taking away care from the patients who we claim we care about serving. And so I think the market is speaking loudly and doing a lot of crazy and wild things in America. It's probably a little bit more urban than rural at the moment where a lot of the money is, but I think it'll be curious to see what the market does when Walmart now is the provider of healthcare in rural Florida and Arkansas. I think that's where they're already starting, or Intermountain Healthcare takes care of all of the healthcare in this part of the country. Like there are big market forces at play really quickly, really scary. So I think that it'll be really fun to watch the train wreck.
I want to thank each of you so much for this very, very valuable discussion. It's been really interesting, and I know we could keep asking you questions for another hour at least. but you've helped us cover a lot of ground during this session, and you're welcome to stay and listen to the rest of the meeting as much as you can. At this time, we have a break until 1 p.m. Eastern. Please join us then. We have a great lineup of additional guests and our first lesson, in addition to this first listening session of the day. So we'll see you back here at 1 p.m. Eastern. Thank you.
Produced by the U.S. Department of Health and Human Services.